Welcome once again in the third and last session of this today teleconference. In the last sessions we have discussed about the obstructive congenital heart disease. In these sessions we are going to discuss the cyanotic congenital heart disease, and mainly giving the two component. It is cyanosis with the decreased pulmonary blood flow, that's comprised tetralogy of Fallot's and Eisenmenger syndrome, and second is like cyanosis with increased pulmonary blood flow, that is transposition of great vessels as well as on miscellaneous diseases. Friends, in the last sessions we have received the questions from the center of the Ranchi. There is two more questions that we didn't able to address because of shortage of time. But their last queries, whatever they have requested, is the change of the date of the next month teleconference is very difficult, because the date has been fixed before 6 months, and in this position or in this point we really cannot change the date. We are very sorry for that, but right now I would like to inform the next teleconference date is on 17th November 2007 in the same time 11 o'clock onward, and the hemodynamics of the congenital heart diseases will be discussed in very detail, because that is entirely different topic. Today we are just giving some little bit overview of these congenital heart diseases, and the question was, please tell about the medical what was the bidirectional shunt and what is Eisenmenger syndrome? Can you just ma'am tell briefly about this, because in the next teleconference we are going to discuss about the hemodynamics only. I think it is the part of the hemodynamics.
Yeah, we will discuss in detail. We have kept that whole 3 session for the hemodynamic of the congenital heart disease in the next teleconference. But just Eisenmenger syndrome. Eisenmenger syndrome means development of pulmonary vascular obstructive disease in shunt lesion, whether it is at the level of atrial, ventricular or the ductal level, leading to bidirection or the right to left shunt. With any shunt lesion, when the pulmonary vascular resistance is lower than the systemic vascular resistance, we get left to right shunt. As the pulmonary vascular resistance is rising, so and increasing and reaching to the level of the systemic vascular resistance, we get bidirectional shunt. And initially bidirectional, leading finally going to the right to left shunt. At the level of ASD, with the VSD non-restrictive, the systolic pressure of the pulmonary artery and the systemic artery are same. So pulmonary arterial hypertension is there, which is of the hyperkinetic type, means pulmonary vascular resistance is low, there is increased pulmonary blood flow. But with the development of pulmonary vascular obstructive disease, systolic pressure will remain same. Obviously it cannot go suprasystemic, because there is large communication between left and the right ventricle, or large PG or large AP window between the left and right circulation. But diastolic pressure started rising, mean pressure rises, and with rise in these pressure, pulmonary vascular resistance rises, leading to reversal of shunt. Initially bidirectional, finally going to the right to left shunt, which is totally preventable thing, but obviously if it is developed, it's not treatable, so should be avoided. At the level of atrial septal defect, PA pressures can go suprasystemic, because the communication is at the level of the atria. RV pressure can super exceed the systemic pressure, which cannot occur at the VSD or PGA or AP window level. So with the ASD, obviously as the RV pressures rises, even RV pressure are not systemic, rise in the RV diastolic pressure. With development of the pulmonary arterial hypertension in ASD, RV diastolic pressure rising means RA pressure is rising. RA pressure rising means RA pressure are higher than the LA pressure. We can get right to left shunt or bidirectional shunt even in subsystemic PA pressures. So hemodynamic at the level of atria and at the level of ventricle or ductal level are different, from going from increased pulmonary blood flow situation to the decreased pulmonary blood flow situation, that is Eisenmenger. It's very wide thing. We will discuss in detail. It's just in short, but we will definitely go. We have to describe these things in detail. In very one line, it's not possible to define all these things.
May I add that this bidirectional shunt in a classical Eisenmenger syndrome, which is associated with the VSD. Here, the bidirectional shunt means that there is a right to left shunt during systole and there is a left to right shunt during diastole, because during the evolution of Eisenmenger, the right ventricular diastolic pressure would be still lower and the left ventricular diastolic pressure would be high. So in diastole we will get a left to right shunt, and in systole we are getting a right to left shunt. So this is the meaning of a bidirectional shunt.
Now I think we should start with the main topic, that is cyanotic congenital heart disease.
Now come to the cyanotic congenital heart disease. Cyanotic congenital heart disease, though it includes many of the defects, just try to summarize in three groups. Cyanosis with decreased pulmonary blood flow, which is, one is the TOF physiology, another is the Eisenmenger. One is treatable, another is non-treatable. Then the cyanosis with increased pulmonary blood flow, that comes the admixture lesion. Here we describe about the transposition of great vessels and the TAPVC. Miscellaneous group not classified in these two are the Epstein anomaly and the left SVC2 left atria present with the cyanosis. First is the cyanosis with decreased pulmonary blood flow. Here we are describing about cyanosis, decreased pulmonary blood flow, normal PA pressure, that is the tetralogy of Fallot physiology. The child presents with the cyanosis, depending upon the severity of pulmonary stenosis, may start in early infancy. Usually there is history cyanosis starting after the infancy. History of cyanotic spell, that is excessive crying, irritability after some stimuli going to the deeply cyanosed child. No, usually there is no history of congestive heart failure. There may be history of cerebrovascular accident or the cerebral abscess.
Here late onset cyanosis means onset of cyanosis after neonatal age. Now late onset cyanosis doesn't mean that it's in the childhood, which is the case in Eisenmenger. A VSD turning into Eisenmenger would be a late onset of cyanosis which is in childhood. Here we have used this word to differentiate it from the transposition physiology, which is the admixture lesion, which presents with cyanosis since birth. So that is one thing I would like to highlight.
On examination, usually there is no cardiomegaly or CHF. Second heart sound is single. P2 is soft and delayed. Here P2 is soft because with pulmonary stenosis, the flow of the right ventricular outflow dominantly direct through the VSD towards the left side. So pulmonary blood flow is reduced, leading to softening of the second heart sound. Pulmonary ejection murmur related to the pulmonary blood flow. With critical stenosis, we hardly get an ejection systolic murmur. With good forward flow, we get a good audible systolic murmur, grade 3/6 intensity. And if there is rectus arteriosus or the collateral spontaneous murmur, will be audible.
Now these all findings are classical findings, which is the usual presentation. Medical science is not an absolute science. We have exception to everything. But whatever we are mentioning here are the classical and the usual findings. You can have a tetralogy with such a severe stenosis that it might present in early infancy, early neonatal age, or you can have a tetralogy with a very mild stenosis which can present in a very late age. So this, whatever we are mentioning here, is the usual presentation of a tetralogy physiology, and TOF is one of the prototype of that. So as a whole group, it is TOF physiology, which have a similar presentation. Madam, please.
TOF physiology, which we have discussed, is basically there is pulmonary stenosis and there is a large communication between the two ventricles leading to right to left shunt. So VSD PS physiology is the tetralogy of Fallot physiology. It includes the common is the tetralogy of Fallot. You all know there is VSD, there is pulmonary stenosis. Then the single ventricle physiology, one is tricuspid atresia or single ventricle of any type with pulmonary stenosis. PS has to be there. Then the AV canal defect with pulmonary stenosis, transposition of great vessels with pulmonary stenosis, double outer right ventricle with pulmonary stenosis, or the univentricular hearts. So these all things come under the TOF physiology. In general, on broad, they all have the similar presentation, but there are some salient features which differentiate the child, keep the child into a particular, we can just narrow down the diagnosis by going.
So this is a bedside diagnosis. Whenever you see a patient with these kind of findings, you can say that based on my clinical examination, this child fits into a TOF physiology or VSD PS physiology. And depending on the ECG and X-ray finding, you can further narrow down your possibility.
But even on clinical, you can just narrow down your
yeah, there are some
diagnosis.
silent
There's some important things.
Subtle features.
Though, like LV type of apex. LV type of apex, usually with TOF physiology, with tetralogy of Fallot, we get right ventricular type of apex. But if it is of left ventricular type, which we get in tricuspid atresia, DORV, or the single ventricle. So we can think for these things. Very important thing is the pulsation in the second left intercostal space. That is the incorrected transposition of great vessels with VSD pulmonary stenosis. Aorta, which is there in the left second intercostal space and dilated because of the pulmonary stenosis physiology, we can feel the pulsation. Murmur louder than the cyanosis. Child is deeply cyanosed. Usually the intensity of murmur is proportional to the severity of cyanosis in tetralogy is inversely proportional to the severity of cyanosis with tetralogy of Fallot physiology. But when murmur is louder, we have to look that the shunt VSD is functioning. This is we get in the transposition of great vessels or the DORV with the malposed great vessel basically. Then pansystolic murmur in tetralogy of Fallot physiology we get with AV septal defect. Means there is AV regurgitation, we are hearing that murmur. Or LTGA, there is tricuspid regurgitation, which is very common. Double outlet right ventricle, VSD is functioning, we get the pansystolic murmur of that. Tricuspid atresia, VSD is restrictive and usually that is the site of pulmonary stenosis. So we get the pansystolic murmur. So in TOF physiology, if we get the pansystolic murmur, we have to think for these diagnoses. Then if there is murmur of PR, pulmonary regurgitation, the rare variant of tetralogy of Fallot, which occur in about 2 to 5% of cases of tetralogy of Fallot, is the absent pulmonary valve syndrome. Pulmonary valve leaflets are just rudimentary or absent in that cases. So we get the to and fro murmur, sawtooth murmur in case of the absent pulmonary valve syndrome.
Here in absent pulmonary valve syndrome, the obstruction in the RVOT is at the level of pulmonary annulus. The annulus is hypoplastic, which leads to the obstruction to the right ventricular outflow tract. It is not a valvular obstruction, it is not an infundibular obstruction, which is the subvalvular obstruction, which is classically seen in tetralogy. So they have obstruction due to hypoplastic or small annulus, pulmonary annulus. So they are TOF because they have VSD, they have a PS which is at the annular level with an absent pulmonary valve which is leaking. So there is to and fro motion. So murmur is also characteristically to and fro.
On the X-ray, the classical tetralogy of Fallot, we get no cardiomegaly, RV type of apex and the decreased pulmonary blood flow. You can see the chest X-ray PA view of a child with tetralogy of Fallot. RV type of apex, pulmonary artery segment is not prominent, decreased pulmonary blood flow and the right aortic arch. This is the indentation of the right aortic arch on the trachea, very classically seen in this. This is the usual X-ray for the tetralogy of Fallot. Right aortic arch in TOF we find around in 25% of cases. On X-ray we can narrow down our diagnosis with DORV or DTGA. Usually there is mild cardiomegaly. RV type of effects will be there with pulmonary blood flow low, but usually it is more than the tetralogy of Fallot. Then tricuspid atresia. With tricuspid atresia, the important thing is the LV type of apex plus prominence of the superior vena cava, as the RA pressure has to be higher than the LA pressure in tricuspid atresia. Right-sided AV valve is closed, it is atretic, so blood has to flow from the RA to LA. So RA pressure has to be higher than the LA pressure. So RA will be prominent plus SVC, because of that SVC will be prominent. So we get prominent SVC, LV type of apex and the decreased pulmonary blood flow. Then the LTGA, that is corrected TGA with VSD PS physiology. Very classical thing is the prominent of the aorta, ascending aorta on the left side. This is the case of the child with situs solitus dextrocardia with VSD PS physiology, and there was AVVA discordance, means corrected transposition of great vessels. So this is just inverted image of the heart, but on the left side you can see the aorta is very prominent. Clinically we can feel this aorta, which were equivalent to the pulsation in the second left intercostal space.
The corrected TGA is also known as the LTGA. Here L is because of the L malposed aorta. So L stands for a malposed aorta which is not at its normal position, and L position means the aorta is left and anterior. Normally aorta is right and posterior to the pulmonary artery. In L malposed aorta or in LTGA, the aorta is left and anterior. So because of its malposition, in X-ray we will get a prominence of the left aorta on the left sided border of the heart. In the X-ray we have shown a dextrocardia. That is why we are getting a prominent shadow of the L malposed aorta. So the nomenclature of LTGA and DTGA is based on the location of the aorta.
This is the one X-ray of the rare variant of tetralogy of Fallot. You can see there is cardiomegaly with TOF with absent pulmonary valve, as there is pulmonary regurgitation. Pulmonary regurgitation is there, means RV volume load is also there with pressure load and the volume load. So there has to be cardiomegaly. Usually presentation is with the cyanosis and the CHF in early phase, early infancy. So there is cardiomegaly, very massively dilated central pulmonary artery. These are classical features of the absent pulmonary valve syndrome. Grossly dilated PA, decreased pulmonary blood flow, plus there is cardiomegaly. Just in very short, management of the TOF physiology. It's basically degree of cyanosis and the anatomy of the heart defects which define the management options. Severity of cyanosis means time of intervention. If child is very blue in neonatal period or in very early infancy, child is very blue, having recurrent cyanotic spell, not stable after treating the precipitating factors, we have to intervene. At our institute, the policy for tetralogy of Fallot with adequate anatomy means pulmonary arteries are normal, coronary is normal, there is one VST, no other associated defect. We do total correction after 6 months of age. Total correction means closure of VSD plus relief of infantile stenosis. If child is small, having this problem, we go for the PT shunt. And for the transposition of great vessels or DORV means basically malposed great vessels, we have to require conduit. So BT shunt in infancy and the total correction usually delayed up to 2 years of age, because conduit will be required, and early, if we place the conduit in early infancy, we have to change the conduit by the end of the infancy. So just to avoid these reoperations, we do total corrections, means putting the conduit and VSD closure after 2 years of age, and shunt if child is having problem before that. Then for the single ventricle physiology, the treatment plan is fixed. If child is having recurrent cyanotic spell or very blue, saturation is falling below 70%, rising hemoglobin and hematocrit, we go for the BT shunt if child is less than 6 months of age. If he is more than 6 months of age, we go for the gland shunt. Gland shunt means there is single ventricle, we have to bypass the systemic venous return to the pulmonary circulation. So we connect the superior vena cava to the right pulmonary artery, that is the bidirectional gland shunt. After 2 years of age, we do the Fontan, means completion of Fontan, that is gland which we have done, and then connect the IVC also to the right pulmonary artery. So completing the whole of the systemic venous return, we are directing to the pulmonary circulation, and then we are relieving the cyanosis. So whole of the systemic venous return, deoxygenated blood going to pulmonary circulation, then pulmonary venous return going to the left-sided and to the systemic aorta. So this is just in very
I think so, if I could understand, the whole thing is that the mainstay of treatment for TOF physiology is surgery. There is no significant role of any percutaneous intervention. And second thing is, the surgery can be single stage, 2 stage or 3 stage depending on the anatomy. The total correction word is applicable when we have two adequate size ventricle and we know that we can use them to their maximum capacity. If the two ventricles are not of adequate size, that means the patient is having a single ventricle type of anatomy, then we require a three-stage surgery which consists of BT shunt followed by a Glenn shunt and a Fontaine operation, which is a three-stage surgery. While in case of tetralogy with a good adequate two ventricles, we can go for a BT shunt if the child is symptomatic in early infancy, or followed by a total correction, or if the child is symptomatically okay, then and we can delay the surgery till around 1 year, then we can go for total correction directly. Madam, please.
Now come to the admixture lesions. What is admixture lesion? Admixture lesion when there is mixing of the systemic and the pulmonary venous returns, leading to the features of the cyanosis and the CHF. There is no pulmonary pressure with these conditions may be normal, or there may be pulmonary arterial hypertension. But this is the non-pulmonary stenosis physiology. This group include the transposition of great vessels, TAPVC, and the single ventricle physiology without the pulmonary stenosis. The presentation is, first I will discuss about the transposition of great vessels. DTGA means complete transposition of great vessels with intact ventricular septum. With transposition of great vessels, our circulation is in parallel circulation. The systemic venous return is coming to the right side and going to the aorta, and on the left side pulmonary circulation is returning to left side and going to the pulmonary arteries. So we need some communication at the level of atria, ventricular, or the great vessels level for the child survival. With intact ventricular septum, it is usually the PFO, patent foramen ovale, or ASD, which is the reason for the survival of baby. So as the duct closes after 3-4 days of life, child come to us with cyanosis. Intense cyanosis is the main presentation with transposition complete TGA with intact ventricular septum. If there is large VSD or large PTA, cyanosis may not be very significant feature. So mild cyanosis with CHF is the usual presentation. CHF occurs slightly early than the usual VSD by the 4 to 6 weeks of age. With TAPVC unobstructed, again here mixing is occurring at the level of the systemic and the pulmonary venous return. So presentation is cyanosis and the CHF. Obstructed TAPVC, which is a cardiac emergency, cardiac surgical emergency. The child newborn present to us with marked cyanosis and CHF with X-ray showing ground glass appearance. Usually these kids are diagnosed as a case of respiratory distress syndrome, and then as cyanosis persisting referred to us. So suspicion of obstructed TAPVC is very important in early neonatal period because delay will cause much delay, and surgical outcome are not good if we delay the surgery in obstructed TAPVC. For examination with admixture lesions, cardiomegaly is usually there, as there is increased pulmonary blood flow, whether it is transposition of great vessels or TAPVC leading to hyperkinetic precordium. As for normal second heart sound, in transposition of great vessels, transposition means anteroposterior. Aorta is not in its usual position, it is anteriorly and pulmonary arteries are posteriorly. When pulmonary artery posteriorly, we do not hear P2 component very clearly. So because of that, second heart sound is single, or P2 is not audible with transposition of great vessels. While with TAPVC we get loud P2, there is increased pulmonary blood flow occurring at the level, pre-tricuspid level, and it is wide and fixed split as with the atrial septal defect. Ejection systolic murmur usually may be prominent or may not be, varying from 1 to 4 grade by 6. With transposition, again, as the great vessels are malposed, pulmonary artery are posteriorly, ejection systolic murmur is not so prominent, as we get the flow murmur, which is in pulmonary outfront, which is posterior. S3 and MDR because of the increased pulmonary blood flow.
So on the whole, the admixture lesions are the lesions in which there is mixing of the complete mixing of the blood. So TGA intact septum is an exception, because unless until there is a good communication, it doesn't qualify to be as a admixture lesion. But for a proper survival of any TGA, intact septum or VSD, we have to have a good mixing chamber. So admixture lesion are those. Here I would like to say that the nomenclature of this thing is in continuation with the pre-tricuspid shunt. When we say that the shunts can be, the lesion can be either shunt lesion, an obstructive lesion, TOF lesion, and a admixture physiology. These are the four broad groups. And in the admixture lesion, there would be complete mixing of the blood. And in admixture lesion, usually if there is no obstruction, there is minimal cyanosis, and they present early. And they present with minimal cyanosis provided there is good communication and no obstruction, and they can be misinterpreted, and their manifestation would be with increased pulmonary blood flow with congestive failure. Admixture lesion by nature is characterized by all these factors. Madam, please.
After this clinical, the chest X-ray in admixture lesions, for the TGA, classical X-ray is the agon side appearance. This is the X-ray of a 1 month old infant, newborn with transposition of great vessels with VSD. The pedicle is narrow. It's narrow because the great vessels are superimposed, and there is cardiomegaly plus increased pulmonary blood flow.
And the thymic shadow is also regress early in cyanotic babies. So the mediastinum, which is usually occupied by a large thymus in newborn period, would be absent. So the pedicle, which is narrow due to anterior-posterior great vessel relationship, rather than the usual side-by-side great vessel relationship, would be very prominent. So that gives to the classical egg-on side appearance, narrow pedicle and a broad base.
It's very classically seen in this chest X-ray. Then
another X-ray.
This is the X-ray of a newborn with obstructed TAPVC. This 1 month old child referred with cyanosis and the respiratory distress with CHF. You can see there is no significant cardiomegaly, but background is hazy. This hazy background is because of the pulmonary venous hypertension. So pulmonary venous hypertension, no significant cardiomegaly, and respiratory distress. This is the triad for the obstructed TAPVC.
So this pulmonary venous hypertension is due to the obstruction or to the pulmonary venous return. In obstructive TAPVC, there is anomalous pulmonary venous drainage, and if this anomalous pulmonary venous drainage is getting obstructed, it leads to a back pressure, leads to a pulmonary venous hypertension, which gives this ground glass appearance, and this mimics respiratory distress syndrome.
Basically, there is interstitial fluid, edema basically, which is giving this haziness of the parenchyma,
which looks very much similar to respiratory
distress syndrome. With the unobstructed TAPVC, it is basically cardiomegaly and increased pulmonary blood flow, but depending on the site of drainage, we can get some classical X-rays in unobstructed TAPVC. This is an X-ray of a child with supracardiac TAPVC. Supracardiac TAPVC means all 4 pulmonary veins joining, forming a confluence and draining the innominate vein. So this figure of 8 means upper part. The ascending limb is formed by the vertical vein of the formed by the confluence of all pulmonary veins, then the innominate, then the dilated SVC, and the lower part of 8 circle is formed by the cardiac shadow. So this is the figure of 8 appearance, or the snowman heart in the supracardiac TAPVC. When all 4 pulmonary veins join to SVC only, we get only shadow on this side, on the right side. This part will be absent. Okay, dilated SVC with dilated heart with TAPVC to the SVC. So
now this figure of 8, which is a classical appearance in a supracardiac TAPVC, usually doesn't appear before 2 years of age. So if you are diagnosing a patient of TAPVC on a basis of figure of 8, it cannot be made in a neonate.
Neonatal period.
So please don't look for this thing in a neonate. You are going to get this image only after 2 years, because only in supracardiac TAPVC. Because in supracardiac TAPVC you should have a dilated channel which is above the heart, which constituted by a vertical vein, innominate vein and SVC. So that constitutes the upper part of the 8, and which would be only evident by 2 years of age, not before that. So it's before that it is the thymus which is sitting there. So please don't diagnose a figure of 8 in a smaller child. And this is only in classically supracardiac TAPVC to vertical vein. All the other TAPVCs will not have this thing.
The ECG for all admixture lesions, it's just show tachycardia, and with right side is prominent to right axis deviation, right ventricular hypertrophy, prominent RA because of the RA dilatation. With TGA VSD, again right axis deviation with biventricular of the left side is left ventricular hypertrophy. Here just I want to in very short tell about the treatment of these admixture lesions. For the transposition of great vessels with intact ventricular septum, as child come to us in early neonatal period, means 3-4 days of life as the duct closes, in very blue stage we have to do balloon atrial septostomy, because the atrial communication is only the thing on which the child is surviving. So emergency balloon atrial septostomy followed by the arterial switch. Arterial switch means we switch the transposed great vessels to its normal position, means pulmonary artery to right ventricle, aorta to the left ventricle, which is switch the great vessels, and this can be done by the 4 weeks of the life, within the 4 weeks of life. If we delay beyond that, we have to change our surgical option. If child come to us after 1 month of age, as left ventricle is facing the pulmonary artery, which is low pressure circuit, LV start regressing. LV start regressing means we cannot use it for the systemic ventricle. In that condition, we have to prepare the left ventricle. We have to do 2-stage switch, means left ventricle pulmonary artery binding, VT shunt to prepare the left ventricle, followed by arterial switch, or the staining means atrial switch, changing the circulation at the level of atria, which direct the blood from the systemic venous return to the left side and the pulmonary venous return towards the right side, which is not a good option. So best thing is the transposition of great vessels with intact ventricular septum is the arterial switch operation, which ideally should be done as the left ventricle remain prepared by 1 month of age, within 1 month of age, sorry. Then with VSD, LV is prepared, we have a large communication between 2 ventricles, so it is the total correction means VSD closure plus arterial switch, 6 to 8 weeks of life. For the total anomalous pulmonary venous connection, surgery at the time of diagnosis. There is no need of intervention, it's just surgery. For obstructed TAPVC, obviously it is the emergency neonatal surgery. Then for DORV without PS, depending on the great vessels relation, we have to do surgery. It is either only VSD closure, or if it is TOF physiology, we have to go for the transposition route. For the single ventricle physiology, tricuspid atresia or single ventricle physiology, as there is no pulmonary stenosis, in this condition we have to create pulmonary stenosis to prevent the pulmonary circulation. So pulmonary artery bending means surgical, we have to bind the pulmonary arteries to protect the PA from the systemic circulation by the 8 to 10 weeks of life. After creating this pulmonary stenosis, we have to do again next stage means gland 6 months to 1 year of age, Fontan completion after 2 years of age. Stages are same. With pulmonary stenosis, severe cyanosis, we have to do BT shunt. Here without pulmonary stenosis, we have to protect pulmonary artery, so we have to do the pulmonary artery banding. For the truncus arteriosus, we have not discussed about the truncus arteriosus, but in very short I just want to say, truncus arteriosus means pulmonary artery, aorta and coronary arteries are arising from a same trunk. Means a common trunk is arising from heart with VSD giving rise to the PA, aorta and the coronary arteries. As pulmonary artery is directly arising from aorta, we have to intervene early than the usual VSD, means surgery by 6 to 10 weeks of life, second, third month of life.
So in short, the management which we have discussed is, for a single ventricle physiology, the treatment would be the same 3-stage procedure. Here, because the admixture lesion is in stage of increased pulmonary blood flow, so we have to decrease it. If we compare this situation with a TOF physiology, where we have a single ventricle type of physiology with a TOF, with a decreased pulmonary blood flow, there we have to augment or increase the pulmonary blood flow by putting a BT shunt, which is a Blalock toxic shunt, to a pulmonary artery with a connection from aorta, to augment the pulmonary blood flow, so that the cyanosis decreases and the patient can be palliated for that area, for that period. Here, because the pulmonary blood flow is already in excess, we have to decrease it by putting a band, so that the patient will not develop pulmonary vascular obstructive disease. The rest of the 2 steps are the same, a Glenn shunt and a Fontan. Here, but we have to be very aggressive. The pulmonary artery banding has to be done before 3 months of age, that is around 10 weeks, because after that the vascular changes starts appearing, and for a single ventricular repair we require absolutely low pulmonary vascular resistance. The pulmonary vascular resistance should be around 4 Wood units per meter square, which is very near to the normal, which is around 1 to 3. So the treatment remains the same. Madam, please.
Now come the Epstein's anomaly, some miscellaneous group. Epstein's anomaly means tricuspid valve is displaced towards the cavity of the right ventricle into the. So we have functionally very small right ventricular cavity, and the upper part of right ventricle become atrialized. Means grossly dilated RA, atrialized RV, then the small functioning RV cavity. In this condition, right to left shunt occur across the ASD as there is significant tricuspid regurgitation. On examination, precordium is white. There is no heave or hyperdynamic precordium. Multiple sounds. We hear split first heart sound, split second heart sound. So because of these multiple sounds, very classically, if we put the stethoscope on the chest of a child with Epstein's anomaly, multiple 1, 2, 3, 4 sounds we hear, with very scratchy tricuspid murmur. And we have to differentiate this thing from the pulmonary stenosis with intact ventricular septum. This is the chest X-ray of a child with Epstein's anomaly, grossly dilated heart with normal or just decreased pulmonary blood flow. If there is atrial right to left shunt, pulmonary blood flow will be low with Epstein's anomaly. To differentiate this from the pulmonary stenosis with intact ventricular septum with significant TR, we will get prominent pulmonary artery segment with pulmonary stenosis, because there is posterior dilatation in pulmonary stenosis, which is a very good treatable lesion. Means we can just do balloon dilatation of pulmonary valve and it's normal. But with Epstein's anomaly, our treatment option is only surgical, and results are valve repair of tricuspid valve in Epstein's anomaly are not so satisfying. So we have to differentiate these two things, which is treatable, which is we have the not very good surgical options.
So in both the condition there is tricuspid regurgitation. In Epstein anomaly, due to the malformed valve, tricuspid valve, there is tricuspid regurgitation, but it is a low pressure TR, because the right ventricle is hypoplastic and it is not generating adequate pressure. So the tricuspid regurgitation would be due to the malformed vessel, malformed valve leaflets. While in case of PSTR, that is pulmonary stenosis with tricuspid regurgitation, the tricuspid regurgitation is a high pressure TR, because the right ventricle is facing a very high pressure due to a outflow obstruction at the pulmonary level. So the murmur and the intensity of the TR murmur would be harsher in a high pressure TR as compared to a low pressure TR, because both the patients will be presenting with cyanosis and will have features of LV dysfunction. Because a patient, RV dysfunction, because the patient will have cardiomegaly, will have cyanosis, will have features of right ventricular dysfunction in both the condition. It is the intensity of the high pressure TR murmur as well as the multiple clicks which differentiates the two conditions.
Plus presence of RV heave.
Yeah, the right ventricular pressure would be high in PSTR, in pulmonary stenosis TR. So the right ventricular left parasternal heave due to hypertrophied RV would be there in a patient with PSTR, as compared to an Epstein anomaly where right ventricle is hypoplastic. So right ventricle would not be taking part, and RV heave is unusual and a very rare finding which is not classically described.
This is the ECG, 12-lead ECG of a child with Epstein's anomaly. The classical ECG finding in Epstein's anomaly, as there is no hypertrophy, we get low voltage right-sided chest lead, we get low voltage QRS complexes, tall P wave, also called as Himalayan P wave. You can see very tall P waves, prolonged PR interval, wide QRS complexes, and the low voltage QRS in the right-sided leads. This ECG is showing very typical of all features of the Epstein's anomaly ECG. In addition to this, we may get delta wave, means WPW syndrome is common with the Epstein's anomaly, plus other features of arrhythmia. We can get any type of arrhythmia in Epstein's anomaly. Just to differentiate this from the PSTR physiology which we have just discussed now, with PSTR we get right ventricular hypertrophy. The same, almost same ECG which I have shown in the previous part of this talk. RV forces are persisting from V1 towards the V5. There is no transition up to this level. So very high QRS voltages, RA enlargement will be there with PSTR also, but with the Epstein anomaly, low voltage QRS complexes, no hypertrophy basically.
Yeah.
I think so. We have come to the end of the session, but just to highlight the last point, that if you compare the V1 to V3 of a Epstein with the V1 to V3 of a PSTR, the presence of R wave up more than S wave favors PS because of RVH, while in Epstein's you will never get RVH because of hypoplastic RV.
Yeah, thank you very much to Dr. Munish as well as Dr. Prashant. And to conclude these sessions, I would like to say in these sessions we have basically deal with the congenital cyanotic heart disease, which comprise the cyanotic with decrease as well as increase pulmonary blood flow. And Dr. Munish and Dr. Prashant also described about the TOF. Within that heading, they described about the TOF physiologies, the Epstein anomaly, and transposition of blood vessels. They explain the etiology of these diseases, clinical features, X-ray as well as ECG features of those diseases, and little bit management. Because actually within this very short period we cannot describe each and everything. In the next teleconference sessions will be on 17 November, and topic will be the hemodynamics of the congenital heart disease, because that's some student has requested to make it.
We would welcome any comments and any of your dear suggestion regarding our present talk and the need
For the future also.
Because this topic is a relatively uncommon thing, and it is difficult to get everything and difficult to understand everything in one sitting.
Yeah.
But since there is a constraint of time, and so we have to manage in this, but we will try our level best from our team, that we will try to answer your queries and make them understand this congenital heart disease, which is enigma for everybody. Even those practicing cardiologists will find this thing little bit difficult to understand.
Yeah. So dear friends, we need definitely feedback from all of yours. Basically all of you have my mobile number as well as my email ID. So please tell me which type of presentation, like this PowerPoint presentation you required, or you require some blackboard presentation where somebody will draw the diagram and explain you in a better way. So with these words, I would like to thanks to all of you, and I would like to thanks to students sitting over here in our studio, students of all the regional centers as well as other centers, the regional directors who are the making comfortable to our students to view this program, as well as the team of the EMPC. And before ending today's sessions, I would like to say Happy Diwali to all of you. Thank you very much.
Thank you.